Welcome back. Good afternoon. That was a delicious dinner. Did everyone have all of the chocolate mousse? Yes. Oh, that was really good. Thank you very much, Blackhat, for that. That was very tasty. So this morning we've covered the pathophysiology, and we've looked a little bit about beginning to test, how to look at the area, and we've started to think about considerations around trauma-informed care. How do we handle a patient in a way that tells them that they are safe, so that we can just calm down their autonomic nervous system a little bit and allow us to get more quickly to the point of what we're trying to achieve. Now we're going to go on to the subjective assessment, and after we've done subjectives, on cue, it's back. On cue, once we've done the subjective assessment, we're going to do some fun maths, and it's really fun, I promise. What I want you to do now is to take 30 seconds to write down when you are doing a subjective assessment of a patient. When a patient comes into clinic, for 30 seconds I want you to brainstorm all of the things that you want to ask them. What do you need to get out of an assessment? Ready, steady, go. I might turn it into a minute. Halfway done? 20 seconds. Okay, heads up. Now, I want you to think about yourself as a patient. The last time you saw your doctor, the last time you saw a healthcare provider. As a patient, what do you want to get from a session? Your patient's coming to physiotherapy, what do they want to achieve in that subjective session? Okay, 1 minute, go. Twenty seconds left. Okay, heads up. So, starting in the back corner with Tina, from a physio perspective, give me one thing, everybody give me one thing that we want to get out of that session. Start us off, Tina.
How does your complaints or symptoms have an influence on your quality of life?
Okay. Pain and quality of life. So, present condition. Okay?
When did it start?
So, history of present condition. Yeah?
I don't know how to say it in English, but wat ik zal het eerder aan het zeggen, wat is eigenlijk de hulpvraag? Wat is eigenlijk Waarom nog die patiënt komt? Why are patients coming to you?
Okay.
What is this?
Why? What is the problem? Thanks, Christy.
What gives you the most pain?
Yeah. So, tags or pain description. In the corner.
How many children?
Yeah. So, obstetric history.
In general, the behavior on the toilets, how they go to the toilets, how.
Yeah, so toilet function, which is really about kind of defecation or voiding dynamics. Hilda?
Review of pain.
Yeah, site of pain.
Do you do sports and which sports?
Yeah, hobbies, sports, and that speaks to kind of quality of life as well.
Do you take pain medication?
Yeah, so drug history, medication history, yeah.
What's your self-care? What are you doing?
Self-care and coping skills.
What do you expect from the physio?
Expectations.
How much does it bother?
Yeah, so degree of bother.
What therapies did you already try?
Yeah, previous treatments and possibly investigations. Coming forward. Sorry, I can't see your badge.
I was thinking.
It's hard.
Yeah. Yeah, was also by toilet function. Other things than that.
That's okay. We've covered quite a lot so far.
How is it about your drinking?
Drinking, yeah, so fluids.
How long do you have already these complaints?
Yeah, so kind of history of pain, which speaks to the history of our present complaint.
Yeah. How did the pain start?
So,
Was there an accident or what's the cause of the pain? The cause.
yeah, okay.
Is there a cause?
Okay, the only other thing we haven't added is past medical history,
And work.
investigations, how neurodynamics, going scans,
What makes it better? What makes it worse?
axonesis. Do you call it axonesis?
No.
Okay, aggravating and easing factors. Relationships, so sex. Relationships, which is different to the relationships, but it's relationships and sex. Anything else?
Quality of your sleep.
Yes, sleep is key.
Maybe genetics.
Yeah. Are you a twin? And does your twin have, you're a monozygotic twin and your twin has BPS? Great, okay. So, starting at the front here, we're going to go with what the patient. As a patient, what are you looking to get from this session?
As a patient, I want that my physiotherapist sees what I do not see. Links.
Okay, so you're wanting to...
A bigger picture.
Yeah. So understand what's wrong with me.
Yeah.
Listen to the complaint.
Listen to my story.
We're going to go this way, but you can shout out in a minute. Yeah, we want to be listened to. Listen to me, hear my story.
She takes time for me.
Yeah, time. Yeah, having that time. A time with someone listening and caring. Someone listening and caring.
Also, so say looking to the more global aspects.
Look or know all of me. I want them to know all of me and what's going on.
I don't want to hear a long list of all the things or exercises I have to do.
Okay, so to not burden me.
Ja, dan come motivated, be motivated.
Yeah.
Maybe get some information,
Yeah.
education.
Information about what's going on, why I've got this pain, why is there a problem?
Yeah, it's the same direction to I want that I get questions that are really pointed to and that I explain why they ask the questions.
Yeah. So answer my questions.
If you had already, I had already different treatments, but I don't use anything of those things to see what she understands, what.
Okay. To understand my treatments and why I've had them and why they haven't worked. Okay. Pass.
Taken seriously.
Yeah. I don't want to be brushed off as another woman being hysterical in pain.
There's a conversation.
Yeah. I don't want someone to tell me how I am feeling. I want them to have a conversation with me.
The thing I would think is important that you have a bit of goals or not goals but
A plan?
a plan.
Yeah. To have a plan. I want to know what we're going to do to get me better, what you're going to do to get me better, what we can do. Yeah? So that's two ways. You want to come into a session and be confident that the therapist you're seeing knows what's wrong with you and knows how to treat you, but also you want to come away from that session with confidence for yourself that you are going to progress in some way or that it was helpful. Christine?
Sometimes you don't have any confidence anymore and they ask the question, can you still have one?
Yeah? Can you help me? So that's about hope. Coming away with some hope.
Yeah, I think it's already said a little bit, like taking seriously. For me, it's important that when I go to someone that they really look at me, not that they always.
Yes.
An open.
You guys are easy to work with because you're a really excellent group. The stuff we're going to, honestly, easy. This is going to make sense for you.
Exercise or things to do at home.
How can I help myself?
Yes.
Yeah. Sorry, Tina. Right at the end.
Yeah, for me also the treatment strategy plan.
Yeah. Plan. Fab. Laura, anything to add to either side?
I think I'm always looking for someone to admit if they don't know the answer.
Yeah. And so that's about
Honesty.
Reassuring.
Yeah. And
It's-
that kind of collaborative feeling of like, okay, well maybe we need to do this together. And then I would also say unconditional love is what I'm looking for from my
And that's some people. This often comes up, but I do believe that we need a little bit of that. You don't have to like your patients, but you have to give them some love. But love is, that's how I interpret it, and that's my language for how I would say I go into every interaction, including teaching, loving you all, giving you of myself within boundaries. Yeah, and that's how effective healthcare is. Right. That's a lot. That's a lot. Which side is more important? Both are important. I would say in your first session, this is more important. And the art of what we do is achieving some of this by doing this. By listening, by being honest if you don't understand or don't know something, writing it down, saying, I'll look that up, thank you. By giving them hope, giving them security, confidence, safety, all of that stuff. Now, when we're talking about patients who are who have trauma or have chronic pain, and potentially, or specifically BPS patients, we want to be thinking about how can we be as effective as we want to be, how can we be quickly effective and achieve as much of that as we can in our first session. And there are tips and tricks to achieve that. So this is the subjective demand of UK physiotherapists. These are all of the things that we have to do in our subjective. We didn't mention red and yellow flags. The yellow flags still exist, they shouldn't. The objective, from our point of view, says an appropriate objective. It doesn't say you have to palpate and observe and blah, 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 blah. It just says appropriate. And then we have to have some form of questionnaire or outcome management, goals and plan in every session. But I give you permission to do nothing more than a subjective assessment for 3 or 4 sessions if you need to. I don't know what your insurance demands of you are, but sometimes, quite a lot of the time with these patients, in my clinic I might take 3 sessions of an hour talking to someone before we actually get to the point of doing any objective, and the objective may not be touching them. That's an appropriate objective for that person, because you've got all of this to get through. Do you know how long it is before a physio on average interrupts a patient telling their story? Laura can be quiet, because I know she knows. Can you guess how long it is? Less than that. What? I think the paper I read was 2.4 seconds on average. So literally 2 seconds. Tell me, how can I help you today? Well, I was at the park and, what park was it? Were you there with your son? How did you get there? What were you trying to do at the park? Yeah. So what we know is that when you interrupt someone who's telling their story, they will just keep going and they will keep trying to tell you until they get all of their story out. So the best thing to do in those situations when you realise that someone has something to say, with all patients, is to put your pen down, give them good eye contact, and look like you're interested. Okay? Be interested, yeah. And what kind of ways have we got of showing that we are interested? Yeah, body language. So we're going to talk about body language now. What kind of clinical body language is good body language? First off, you can do no harm by watching Mark Bowden. He's a friend of the family. He's also an actor. Has anyone watched not Game of Thrones? What's it called? Lord of the Rings. Yeah? In the Two Towers, when the orcs are storming the tower, there's like a massive orc army, and there's a rock, and an orc goes on the top and goes, "Ooh!" That's Mark. But in his main job is he's a kind of a body language expert, and he works with prime ministers and presidents and all sorts about body language. I've given you a link to his TED talk at the end. After the course, you will be sent another email with lots of resources and the links. Mark talks about using body language as a way of putting people at ease, and it's really effective. So I've been doing it on all of you guys as much as I can because my back's a bit sore. Simple things. So first off, we stand, if you imagine a doorway, we stand in our doorway. We stand up in our doorway. We don't stand forward of our doorway. We don't stand backwards of our doorway. If we stand backwards of our doorway, I look less interested. Yeah? I'm slouching. I've been trying to do this without pushing my boobs out all day. It's hard as a woman to feel upright without feeling like you're showing the world your boobs. Okay? So we stay in our doorway. The next thing that we do, so say that Ineka's a patient that I'm coming to clinic to get. So these are her notes. This is my pen. It's normally in my hair. There's a difference kind of saying, "Hi Ineka, welcome to physio. Nice to come down to physiotherapy this morning." By doing something like this shows there is a potential here for me to have a weapon. It's a subconscious thing. If I do this, I show you I have no weapons. The first thing I've done every lecture is say, "Hi, welcome everyone." It shows to you I have no weapons. It's a simple hindbrain trick to say, "I am safe, I will not hurt you." And there is a difference with walking and saying, "Good morning, come on down to physiotherapy, it's nice to meet you." The next thing is about being inauthentic with your face. So I want you to turn to each other, turn to the person next to you, and I want you to smile just with your mouth, but have sad eyes. And then I want you to try just raising your eyebrows, but not smiling. By raising your eyebrows, we're just giving, again, a really subjective, a subconscious cue that we're interested. Okay? And one of the best things to do immediately to grab someone's attention and say, I am interested in you, you matter to me, is eye contact, like you said. But more than that, this is the, I used to work till 8 o'clock at night, and there'd always be the complex patient would book in at 7:30, really complex, that needed like an hour and a half of treatment. And I'd walk down the corridor, oh goodness me, I'd get there and I'd say, hi, lovely to see you, come on down. But as long as when you immediately see them, hi, it's really lovely to see you, come on down to physiotherapy, I am interested in you, I value you, I'm making eye contact. What I've also done when I've gone to these two lovely women at the front here is I haven't gone full frontal. Okay? When you sit body to body, yes, we've got a bit more, I normally invade people's space a bit more than this. We've got a table between us, but when we're front on and you're kind of sideways, it's intimidating. And it's not appropriate from a social point of view because we are less able to escape. And the patient needs to be able to escape. So 45-degree angles, very simple. That feels a lot more comfortable, doesn't it? Ish. Yeah? When we're going to people. If you use these really, really simple tricks, patients are slightly more at ease with you, slightly more on board with you, regardless of how you're feeling with your day. And try and do it with everyone and just see the difference it makes to the patients that are normally grumpy and difficult when they come in, because it just puts people a bit more at ease. Where did I leave my cigarette? The next thing is setting up expectations. So when people come into clinic, how do we set up an expectation of the language we're going to use? I mean, not literally French, German, Dutch. You can do that with your literature. But the language around things. So in English, in Welsh English, which is different to English English, people may say, my bladder is weak. Does that mean it leaks? Does that mean I have urgency? People talk, I was talking to Laura about, I had a patient talks about her flower. My flower's broken. Okay? But if you give them an outcome measure beforehand, and my favourite one is the Australian pelvic floor, APFQ, or the Queensland, which has the Queensland questionnaire, which has stress incontinence, so it has bladder questions, bowel questions, prolapse questions, sex questions, all physiological but also a few quality of life. So you can scan it really quickly and go, what's wrong with this person? Where do I need to start? But in that questionnaire it talks about leakage of the bladder. And leakage as a word is not something we would commonly use in English parlance day to day. You know, my tap has some leakage. It's not normal. But it gives them words to use. I have a heaviness. I have a lump in my vagina. Instead of saying it's all coming down, it's falling out. It just feels like everything's going to come out. Does it feel like a lump? Does it feel like a tampon in the wrong place? It gives them words and language, and it's the same with BPS. These are the validated measures for bladder pain. You will have copies of them digitally, which I'll send you a link to the online stuff. The ICSI, ICPI is the most validated. These ones aren't validated in BPS, but I find them useful. So the genital urinary pain index is a really nice measure of genital pain and sexual function. NIH CPSI, I'm guessing you're all using with men anyway. The NIH chronic prostatitis index. Do you use outcome measures, or are you just tired from lunch? No?
Not in English.
Not in English, okay. And the pelvic pain impact questionnaire is a really nice quality of life one that's great for PGP, pelvic girdle pain, as well as pain and sexual dysfunction. Tina will know these, because if you've done Carolyn Van Dijker's course, these ones I also use with every patient. So the central sensitization index, I don't actually use this one every time because I can kind of guess by this point, but you know if they've got a score of over 40 that you're going to maybe work in a different way. The DAS score, depression, anxiety and stress, is a really beautiful one for being able to say, you have scored highly on anxiety, Is that a reflection of how you're feeling? Marvellous. Would you like me to send you to my colleague, or would you like some help with that as part of our physio plan? Okay. And then what Carolyn's course then does is it gives you all of the wonderful within scope of practice ways of dealing with that as a physio. So, right, well, while you're waiting to see my counselling colleague, we're going to start some journaling every day. We're going to do some worry journaling. Or depression, we're going to add in some cardiovascular exercise. Pain catastrophization score, really good. If they get more than 20, it means that you are going to go to town on your pain education, whatever that looks like for that person. But if you can bring down their catastrophization, we know that they have a better outcome with physiotherapy if they have less than a score of 20. And we were talking about it first thing this morning, but the more that I understand of pain, the less I talk about it with patients, unless they ask, because I believe that they understand it more than I do, their pain. Insomnia and self-efficacy, they're helpful as well in the right patient at the right time. That's Carolyn's course. I don't work for them. I did do one course for her because she's a friend. She's one of my research colleagues. We do bits and bobs. You'll see a couple of things that we've done together coming up. But it's really, if you're looking to expand your biopsychosocial, or rather improve your biopsychosocial skills, that course is brilliant. It's all online. I think it's only 4 sessions. Okay, so what do we think of this room? What can you see?
An office.
Yeah, it looks like an office, cold. What about the table, the bed that the patients are on and the things around it? I mean, we all know what those things are. But, you know, if we took my kids in, or if we took someone non-medical in, it's like, does that go up my bum? You know, I've come for a pelvic health physio appointment and they're going to stick that in me. You know, that's quite scary. What about the position of the chairs? They are quite close, aren't they? Yeah, you haven't got that kind of appropriate distance. What about the position of them?
They're not talking to each other.
They're not, and that could be a good thing, because they're not face on. We don't really want them face on. What about the computer? Who does digital notes? Is everyone handwriting? Yeah? Okay. In the UK we're moving a lot. I think about 50% of us are on digital notes now. It works some of the time, but it's a bit like, my phone's not hit. It's a bit like being on your phone. It's a bit rude, a bit socially unacceptable. So you've got to find ways, it's just comedy. All I can hear is a very long fart. Great time. So thinking about how you use your computer, I will, when a patient first comes into me, I will ask them, and how can I help you today? Let them talk for as long as they talk, and when they stop, say, is it alright if I just make some notes on that? I'll be typing, but I move my laptop so they can see what I'm writing a lot of the time, just because of the position that I happen to be in. The other thing to note is the chair that the patient's on needs to be closer to the door than you. Yeah? Amazing, good. Psychologically, again, it's another one of those make me feel safe steps. In the NHS, we're told that we're more important than the patient, and we need to be able to escape and egress. But I would say that it doesn't make for an easier session. So if you can make that person feel like they can escape quicker than you, they're nearer the door, there's no obstacle in their way, again, they're just going to calm down. All of these things, subconscious safety. So this was one of the rooms that I was given in the private hospital. It's an old chapel, it's very pretty, and they've broken it up into different rooms. But they have this massive penis, which is on what I call these desks when, you know, doctors sit behind their huge penises. Laura, you can stop laughing. She's got a head on her hands. Because that's what it is. I went to my kids' primary school to meet the head teacher recently, and he had a room that was kind of long, oblong shaped, so not square. You came in the door and there was a corner seating unit for maybe 10 people, and then a desk that went round a corner, and I could not have reached across the desk. And instead of coming in and shaking my hand, he went straight behind the desk and sat down, and I went, ooh, why do you need to sit behind that big penis? What's your problem? Why are you nervous? Because he didn't come and sit next to me and talk to me. He used his power. So we don't want to have that distance and that power. So in this room, did I show it? No. In this room, I just came round and sat with a patient here, and we had a couple of chairs. And the consultants used to laugh at me, but this is another room I worked in once. What do we think of this? Yeah, this is what gynecology consultants think women want. Pink. And it was really depressing because when you closed these, it was really pink everywhere. But also there was just kind of a lot of equipment out, and these do go up here. Look how big they are, that's as long as my arm. It's really kind of shocking. So I hid all of that away. And actually the rest of the room, over the other side, it doesn't really show it, but there were a couple of chairs here that were sofas and comfortable. So I brought those round, made them the focus as you went in. So it was a nice comfortable seating area. Let's do this, let's have a chat, and then get on to it. It's one of the things to note that was one of the rooms you're going to see the patient tomorrow that has a panic attack. You don't see the panic attack, so I won't put that on video, but when I talk about the room that I took her out into, this was the waiting room. So there was no one ever up here, just me during the day. Nice big sofas, made her a cup of tea. Changing room, but again, very pink and flowers. And this is the room I'm in now. This is when I first went into it. I haven't got an updated picture. But again, a bit bland, lots of, I mean, this is an aesthetic skin, some kind of anaesthetist works there, so she does lots of facials. But it's got lots of tubes and wires, it looks quite scary. So I hide everything behind the corner, which again I don't like doing because it's what's behind there. Is someone watching? Who's behind there? I like people to be able to see everything. But anyway, and I've moved this round, brought the chairs together. Often we're not able to change the space that we're in, but we can move the furniture. So even if you can just put the chairs in a slightly different place, set your day up slightly differently, have less power when the person walks in, go into your room thinking like a patient, and use as many tiny little cues as you can to just bring them safety, and it will make your sessions a lot smoother. Okay, and we've kind of touched on this, but I would say in all of our pain patients we need to be giving the opportunity to tell their story in the way that they want to, and using techniques, which I know a lot, we've talked about this already, but a lot of you had training in things like narrative assessment, but using techniques where patients will tell you everything and then you reiterate to them in the same language that they have said. I mean, not literally French, but in the same words. So someone, what day is it? Yeah, it was day before yesterday, told me that her pain was too burny bad. And that sticks in my mind because it's literally what I wrote, and I said, okay, so the pain was too burny bad on that day. Keep going. Reiterating back to them, I have listened to you, you are valuable to me, I'm interested, so much so that I have the words that you have chosen. Okay? Don't be a nocebo. What's a nocebo? Yeah, it's the opposite of a placebo. So what rubbish have consultants said to your patients? My favourite was a consultant who once stood in a room of patients. We did a pain exploration evening, and we were the pain team, and she was an anaesthetist, and she still is. And she stood there and explained Descartes' theory of pain from the 16th century. And it hurts here, so we inject here, and then the pain spreads, and so then we inject here, and then the pain spreads more, and then we do this injection, and that hurts more, and that tends to hurt, so then we do a neural block. And she said to one of my patients, well, you know, you're going to be in a wheelchair. Your pain is so bad you're going to be in a wheelchair. That's a nocebo. Do you think that patient was in a wheelchair when they came to see me? Yeah? Because they've been told they would be. And that takes a lot of unpicking. So don't do those. You know what they are. Even if you know this yourself. Eve, I'm a optimist. If someone comes with huge grade 4 prolapse, it's hanging out all the time, terrible stress incontinence, I will do everything to find one tiny little positive thing to say. You managed to stand up then without leaking. That was fantastic. That's a really good sign. such a good sign that you're going to be able to improve. Do everything you can to give them realistic but optimal ideas of things that can improve, so that we're not nocebos. So our subconscious safety tricks. We use the room in a way that gives them safety and removes power from us. We use our body language in a way that says, I am upright, I am interested in you. I have raised eyebrows, I'm very interested in all of you. I carry no weapons, I will not hurt you. We set our expectations. You can do that in lots of ways. You can do it with literature beforehand. I like to use outcome measures when they sit in the waiting room. And we allow them to tell us their story. We allow for a narrative assessment. Okay, we're going to play some red flag games now.